Good afternoon, everybody. Thank you very much for joining us this afternoon. This is the free webinar about PCN Incorporation with the well-led provider, MIAB and Hempsons, where you get the opportunity to listen to some frequently asked questions prepared by the experts, and also have your opportunity to ask us questions directly, or for us to answer the questions that you already submitted to us in advance when you registered for this webinar. So I hope you find it useful and tailored to your specific needs at your practices and PCNs. First, we'll start hearing from the medical legal specialist, Rob, who's on the call, and then we'll go to Monty to talk through insurance and risk relevant to incorporated PCNs, and then I will come at the end and talk a little bit about the CQC regulatory framework and how that applies to incorporated PCNs, if at all. And then we'll jump into the Q&As at the end. The team that will introduce themselves as they come on individually include Gary, who's a former practice manager, Monty, who works for MIAB, and Rob, our medical legal expert from Hempsons. And I'm Claire, I'm a GP, and I work for the well-led provider. Just a reminder that we did a webinar on a similar topic several months ago now, which when you get through the recording and the slides after this event in a couple of days' time and you have access to these, you can click on the link to watch it. And it's also on our YouTube channel, where we did a kind of basic overview of incorporation, the pros and cons, what you need to consider, what risks you need to consider, and a little bit about the CQC and how it applies. So that's a good place to start and maybe go back to afterwards if you haven't already caught up with it. But I shall hand over now to Rob to introduce himself and talk you through the first part of our webinar this afternoon. Thanks, Rob.
Okay, thanks very much. So yes, as Claire said, I'm Robert McCartney. I'm an associate here at Hempsons, and I'm in the corporate commercial team specialising in primary care and specifically general practice. One of the many areas that we focus on is the development of primary care networks and collaboration at scale as a whole. Over the past few weeks, through the various communication that's been out, we've been kind of pulling together a list of kind of top questions that we get asked. I've chosen these 7 as kind of general starting points for us to then kind of explore and to consider in a bit more detail. We'll be covering it relatively quickly with the idea I can get through my slides. Each of our colleagues on this call get through the slides, and then we can have a discussion piece on it later. If anybody wants to get into greater detail on any of those points, either raise it in the chat, and I'm sure Gary will pick it up in the kind of second half of our session, or by all means reach out and contact me anytime that you like. So I will start with kind of the big one, really. It's the first question of what are the key benefits of incorporation? So I would preface this by saying that incorporation is not always the best option for every PCN. Certainly there are PCNs who are kind of single practice, large scale PCNs who may not require an incorporation at that stage. There are also those PCNs which are very kind of comfortable in their situation and happy with the level of risk that is associated with working at that level of scale, even if it's across 2, 3, 4, 5 different practices. However, we're increasingly seeing that there is almost a second wave of incorporations happening after the kind of first wave of a few years back, where it was really starting to get momentum, in which there was interest in incorporating to plan for kind of the next stage. And some of the benefits, and probably the most important one, is the limiting of liabilities. So a company by its very nature is limited, so it doesn't have an unlimited cap, which most practices which are partnerships have an unlimited amount of liability upon all the partners involved. The liabilities are therefore easier to identify and to put into a position where they are less likely to have an impact on you as individuals if things go wrong in a worst case scenario. This includes things such as premises issues with staffing matters, and with kind of debts that may kind of accrue from the business. We were asked a separate question about the risks of redundancies arising from the additional roles reimbursement schemes. There is a kind of what
Oh dear, have we lost our lawyer? Is that happening for everyone else?
Yeah, it has. Well, here it has, Claire, I think, definitely.
Oh dear, what a shame. Why don't I suggest I'll just mute him in case he comes back in the kind of scramble. And Monty, can I flip ahead to your bits and then we can come back to...
Absolutely. Go ahead, Claire.
There we are. Like nothing happened. Over to you, Monty.
Excellent. Thank you very much. Hello, everybody. My name is Montrose Bill. I'm medical malpractice manager here at MIAB. We're industry specialists in terms of providing cover for GP practices, individual healthcare practitioners, and generally healthcare businesses across the NHS and primary care sector. We've been going for over 22 years now, have a wealth of experience. And again, as Rob previously said, one of our areas of focus is actually PCNs. Our bread and butter being GP practice. Most of the practices that we actually work with and speak to on a daily basis are signed up to a PCN or GP federation of sorts. So we've been working with PCNs now since their launch in various guises in 2019. Okay, so I think what we need to talk about is really what cover would a PCN actually require. I think when we're contacted on a daily basis, that's the main question. It's a bit of a minefield. We're usually contacted by the PCN manager or a finance officer, just asking what kind of covers do we actually need to take. And as I say, off the back of the launch in 2019, we did an extensive amount of research just to understand what your exposures actually are in terms of the people that you're hiring, in terms of the contracts that you'll actually be undertaking, where you're going to be located, and how the staff are going to be working throughout your network. So we work on a consultative basis, take down all the information, but these are the main areas that we could actually find where your exposure would actually sit and where a claim could come in to actually harm the limited company moving forward. So the first area is professional indemnity. So we'd always recommend professional indemnity. As a PCN, you're almost acting in the management consultancy sort of aspect, or in a management consultancy purpose, should I say. There could be financial loss as a result of the work which you're actually carrying out. Because it's a limited company, you're responsible for the funding. And so you should actually have that type of cover in place just to defend yourself in the event of any claims which are lodged against you. That'll pick up cover for the business and all the clinical directors as well. Management liability is another key area, a fine line between management liability and professional indemnity. Management liability will really cover off the day-to-day management of a business. So it's picking up cover for the board of directors, anybody who's in a position of responsibility, as I say, taking decisions on behalf of that business on a day-to-day basis. So these are all things outside of actual treatment, just running an actual day-to-day business. That could be things like tax investigation, your HR function, health and safety. You're setting the processes and protocols, looking at governance strategy. As I said previously, there's so many pieces of legislation which could actually affect you, and it's changing all the time. So we're going to picking up your directors and officers cover, company legal liability, and your employment practices liability. A key area is employment and public liability. Sorry, employers and public liability. That's really going to pick up cover for basic slips and trips for all of the staff who you actually contract on a day-to-day basis, or any injury that they may cause to member of the public, or any third-party property damage. Again, this is above and beyond the cover which you'd get for a standard GP practice, because the name's going to be in the contract name is going to be in the name of the actual limited company, or jointly in the name of the limited company and the underlying practice. You should actually be looking at additional employers and public liability cover as well. Premises and contents, we don't tend to see that too much. if an actual limited company does actually own, say, laptops, any all risk items which you might be taking around a network, we'd look to cover that as well for you. We have actually seen cases as well where there's been mergers where a practice potentially has lost its funding or lost its actually registration, and it's been moved on to another practice. So we've actually had to pick up the premises as well. By putting together this actual package, what we're doing is we're mitigating all of your risk. Therefore, you don't have to have maybe 5 or 6 different policies to help you. Everything that you do is actually in one place. And at the moment, we believe we're the only broker on the market who's got the ability of insuring you under one particular policy. Next slide, please. Okay, so I mentioned it earlier on, professional indemnity. Why do you actually need it? The cover here is actually above and beyond that you would actually see with CNSGP. We're aware that all of the work you do is normally within a APMS, PMS or GMS or standard NHS contract. But there are claims which you would actually see whereby there's been no bodily injury as a result of treatment, and this is where professional indemnity can help. Typically, the kind of claims that we see are those listed in the slide here. So you're responsible for credentialing of staff. Whilst that staff may actually go on to do something which is clinically negligent, NHS resolutions would pick that up, but there could still be a claim against the business because you didn't actually bring somebody in who was good enough to do that role, or they weren't qualified to do that role, and it went on to lead to an issue. Again, you're providing a professional service. So if you weren't meeting patient quotas, for instance, and funding was actually revoked, or you were paid too much funding, you could be asked to have that returned. We see a number of claims in that area. I think the big one is where we see a lot larger federations or limited company PCNs who, on top of your DES contract or enhanced access service, you might be doing a community care contract, which is commissioned directly with the ICB. And when it comes to actual insurance, you'll see within the contract or the framework contract that it would ask for a commercial policy. So you can't just rely on CNSGP in that instance. You would need to have something which we term as contract certain, i.e. it's dotting the I's, crossing the T's, it's ensuring that you're covered for what it actually says on the tin. So any kind of legal defense costs, you would have it there. Next slide, please. Again, this is a fairly big one, which we see. There's a misconception that employment practices liability is actually picked up under employer's liability. They are 2 different sections of cover. Obviously, I mentioned earlier on, you've got your employers and public liability, which is really there to protect your ARRS roles whilst they're working across the network. It's a legal requirement. It's something that you should have in place, but it doesn't actually pick up any cover if your employee feels that they've been violated in any way, shape or form, or they're unhappy with their treatment at work, or they feel they've been harassed in any way, shape or form. That's where you would require employment practices liability. Majority of people that we speak to, they're either signed up to Peninsula, Citation. If you're a lead GP, you may have membership with the BMA. You also get the EAS, the Employee Assistance Service. But what that doesn't do for you is it doesn't give you any kind of risk transfer, i.e. once it's gone past the point of trying to be a counselling or conciliary service, if there was any request for it going to litigation or you actually found liable that you had done something wrong with your employee, that Peninsula or Citation, they don't normally pick up the legal defence costs and definitely would not pay compensation awards. And that's where you need something robust in place which could assist you. The employment practices liability would be found under our management liability section of cover. And another huge area which you probably need to be aware of, since I believe October 26, there's been a new legislation, legal reforms come out for the Employment Rights Tribunal. So all employees now, regardless of when they're actually employed, they've got the same rights as anyone who's been within the business for more than 2 years. So that's something, again, for you to be aware of. EPL really is an area where we've seen an increase in claims since COVID. And yeah, we get inquiries daily with regard to that, but I just wanted to make it clear that the differences between the 2 covers there. So how much cover do you actually need? Is a $1 million question. We get this all the time. What we tend to do is we would send you what's known as a fact find document. We'd get you to complete all your information in terms of where you're actually positioned, where you are in terms of the structure of your business, what contracts you're undertaking, how many staff you employ, and a breakdown of your staff actually. We like to know how many staff are actually going to just be in an administrative function, how many are actually going to be carrying out clinical work. Those who are carrying out clinical work, will they actually be going into doing care home visits or home visits? Because that would actually make a difference to the limit of cover you require and what your actual overall risk exposure is. But the main two areas for rating factors are actually going to be the size of your business, which is your annual turnover, and what you're paying weekly, monthly, annually in wage costs. The busier you are, the more likely the more likely there is to be a claim, but that's how claims frequency works. We also take into account how long you've actually been trading, and if you have had previous cover, whether there have actually been any claims. But what we'll do is we'll book an actual appointment with yourself, and we'll take you along the journey and sit with you to actually make you understand where your exposures actually lie and what kind of cover you will actually be requiring moving forward. Some of the covers would actually be standard in terms of the employment and public liability, but limits of indemnity for things like professional indemnity, we'll work that in line with your actual annual turnover. Same for things like the management liability when it comes to your directors and officers, company legal, and the EPL cover as well. Again, what other covers should you consider? I think one which is very, very prudent, and one which we always recommend, and we are getting more inquiries, is cyber liability. We picked up on this in the last webinar. However, we appreciate the systems that you use. They belong to the NHS, whether it be System 1 or whether it be EMIS. That is really a platform for you to house or access medical information. The healthcare industry, I believe it's number 2 or 3 behind education in the frequency in terms of the amount of claims which are actually seen for cyber liability. Also, don't get cyber liability confused with, say, data protection, because cyber liability, whilst there are areas of cover where you would get legal defense costs, say under a management liability policy, what that won't actually do for you is if your system goes down as a result of a cyber event, that wouldn't normally be covered. A cyber liability policy would do that for you. In terms of if there was a data breach or if your system was hacked and you went on to affect your patients or another practice, the cyber liability would actually save you the time, and they would actually have a notification system as well, where they would go out to everybody and let them know what's actually happened. They would try and suppress any bad press, as it were. So you'd be covered things like defamation, ransomware, if there was any kind of rewards for getting your system back up and running, which is what a lot of these companies actually do who are trying to hack your system. There's so much more a cyber liability policy can do, rather than the NHS where the system actually goes down and they say, right, we'll get you back up and running. A cyber liability will just give you peace of mind and comfort that they could actually assist you should anything go wrong. And I think a big one in terms of cyber liability as well, the majority of the time, most cyber events actually stem from personal error. It's not actually a case where you've been affected by a virus or any kind of malware. So you've got full data breach cover. Cyber liability will actually pay for any kind of ICO fines as well. Another area where we do recommend cover is if you're actually undertaking any kind of work outside of your standard NHS contracts, you should be actually purchasing full-blown medical malpractice cover. This could be on a small scale if you're doing things like DVLA reports, travel vaccines, fitness to fly, general occupational health checks. All of that requires medical malpractice cover. Whether it's as an individual or as a business, we can look at that for you. Obviously, also, if you're undertaking contracts which are direct with the framework and not standard NHS contracts, you may actually require a full-blown vicarious liability policy. There was a recent noted a recent publication in Pulse whereby there was a GP who actually undertook just a basic fitness test for a sports person below the age of 18, went on to miss something where he went on to have damage to his back, and now that young man is actually claiming quite a bit of compensation from the practice, being that the GP was working for them at the time. So that's something else to consider. Wraparound indemnity. This is really, again, going to be additional cover for your ARRS if required, or any clinical professional who's going to be working for you. Since the launch of CNSGP, it may be that potentially either a group or corporate group indemnity may have been stopped on the basis that you think CNSGP is picking that cover up, or it may be an individual clinician, practitioner may have decided to stop their actual subscription, again, feeling that they're going to be protected by CNSGP. That is not actually the case. You would still need to, anybody who's registered to an association or registered body should maintain their own regulatory cover, or what we term wraparound indemnity. It'll pick up things like fitness to practice, cost of coroner's inquest, any Good Samaritan acts that you may incur, and also cover you for criminal prosecution as well. So that's again something else to consider. So just push that up. Lovely, excellent. So in terms of a robust cover, this is kind of what we suggest a PCN or a GP federation should actually be looking at. As I say, it's very complex. You could have a claim which attaches 2 or 3 different sections of cover. Which one do you actually refer to? Having the one policy where you could have risk which is actually overlapping is really important. That's why we suggest you look at not a one, we wouldn't like to say a one-stop shop, but something which would look after all of your exposure. Then you've got the 2 covers which sit on the outside. So essentially that's kind of a rounded view. There's probably a few more questions that we'll follow on the next slide, which potentially I could look at. I think one of them was the cost of what PCN would actually pay in terms of practice insurance. As you can tell from what you do, it's a lot more complex. A practice insurance policy, if you're looking at a single practice, you could be paying as low as £500. You could be paying up to £5,000. The type of cover that you would actually have under a PCN style contract, or the work that you actually do, would actually attract a lot larger claims. Obviously, if you're looking at things like professional indemnity, if you're looking at claims against an actual business, the type of legal awards which could be paid out could be vast, and that's why you will end up paying a larger premium for a PCN style policy than you would a practice policy. I think another point that we get asked again, because there is a misconception between malpractice and professional indemnities. What happens if we cease trading? Will we require cover for runoff? If you do take professional indemnity, the onus is on yourself to deal with any future claims. The policies which we offer are claims-made insurance policies, i.e., that means you need cover in place at the time of any kind of work, consultation, advice, professional service you provide, and make that claim during a live policy period in order to be indemnified. So if the business were to cease at any time, we do recommend that you look at runoff cover. You would buy that per 12 months, or essentially you could look at a longer term deal, but that's something that we would speak to you about at the time, maybe if you want to think about maybe 3 or 5 years. I believe I've covered off the majority of the questions there in the slides. In terms of the PCNs that we work with, we've been advising, as I say, PCNs really since their launch, since incorporation, definitely over the last 2 years. We work with over 100 PCNs at the moment. We're working with a number more who have sourced cover. It is quite a long tail in terms of buying cover. We tend to speak to PCNs really going back maybe 6 months. We've had PCNs on our books who we've been speaking to since the beginning of the year. They're only now getting to a point where they're looking to purchase cover, because we do appreciate There's a lot of work that you have to do behind the scenes before you can actually start trading. Again, one of the questions that I think we would get is when do I actually buy cover? We would actually say as soon as you know when you've actually started 2Ping staff in, as soon as you're actually limited, I think you're actually starting to get into a lot of negotiation. You're starting to think about where staff are going, what contracts they're actually going to need to actually undertake the work. So we would say look at cover at that particular point. So yeah, I've been talking for a little bit now. So there's probably quite a bit to unpack in there, and I'm sure you may have other questions, but obviously my contact details are there. You can either, if you're not going to ask now, but do feel free to get in contact with us, and we'll set aside some time just to run through it with you.
Thank you, Monty.
No problem.
I won't take too long at all with my CQC bit for two reasons. Firstly, because there's loads of questions that have come in on the chat as well, which we want to give the time to answer. And also because, as I said at the beginning, we'll give you a way to access the slides afterwards when you receive the email from us, so you can peruse them at your own leisure anyway. The most frequently asked question we get about the CQC in relation to limited companies is, do we need to be CQC registered? And Rob was going to talk about this as well. But basically, if your PCN company, your incorporated company, is going to be directly delivering any contracts, for example, some of the DES contracts on behalf of the PCN network practices by way of a subcontract, then yes, you do need to be CQC registered. And you need to be CQC registered before you can do it. So you can't just say, we have applied. You have to actually be a regulated provider. And one of the issues there that's worth bearing in mind is that there's a lot of backlog at the moment with the CQC in terms of processing new registrations. It's taking more than 8 months at the moment. So you need to factor that into your planning if that's your intention at the end of the day with what you want to do with your incorporated company. You need to get that in early. The other questions we tend to get asked are, what's going on with the CQC framework at the moment? There's this new thing, the new single assessment framework. What's that? And what's all of this news that we've been hearing about the CQC essentially not being fit for purpose itself? And how is all of that going to fit in? So let me run through that with you very quickly now. If you're thinking in terms of the old CQC framework and not in terms of the new one, which is called the single assessment framework, then you're missing things out because it's different. The key lines of inquiries have now gone and they've been put in the bin and they've been replaced with something called quality statements. But it's not a simple just change the name. It was a key line of inquiry. It's now a quality statement. There are new ones that have been sprinkled in. So just make sure you're thinking about the new framework. So this is an example from the well-led domain. It's not called domain anymore. It's called key question. There are 2 new bits in it: freedom to speak up and environmental sustainability that people are sometimes missing out on. And because this is a single assessment framework, that means it applies equally to all regulated providers. So whether you're a GP practice, a PCN, a care home, a dentist, or a massive NHS Foundation trust, these are the things you need to be following. So if you're an incorporated PCN thinking about the CQC, then those are the things you need to be thinking about that are in there. The environmental sustainability one is difficult because they've said for the first year they're only going to apply that to NHS trusts, but it's almost the end of the first year now and it's gone a bit quiet about it. So nobody knows what's happening, but it would be worth having it on your radar, I think, anyway. And if you read what the quality statement says, which is basically saying, are you aware of your impact on the environment? Are you trying to do a bit about it? Then most practices or PCNs will have somebody who is a bit keen on this topic, who will be able immediately to either give you ideas of things that you can do quickly to show that you're thinking of the environment, or things that you're actually already doing. So it's a case of just gathering that together so you've got some evidence on it. The freedom to speak up one is new as well. Like I said, it's not a whistleblowing copy and paste. It's a new thing, freedom to speak up. It's different. And the issue we're finding with practices and PCNs, which is sort of unique to the smaller providers, is that it's quite difficult sometimes to have somebody who's a freedom to speak up guardian who is independent from your organisation, because you're so small, somebody that your practice staff feel able to speak to. And here's an example of some practices that have been marked down essentially in CQC inspections this year because they haven't had somebody independent appointed as their freedom to speak up guardian, or they haven't had the option as, in addition to their freedom to speak up guardian, there's somebody else who's independent to the practice. So worth bearing that in mind too. The CQC's focus has now shifted a little bit. It's not a case of now just you need to have all of your policies in place, and therefore if you're a new PCN incorporating, you can copy and paste your practice policies across and change the wording. The CQC is now more interested in you demonstrating how your policy is being effective and working in practice. So sure, they'll want to see your policy, but they'll also want to know that it's working. They'll want to see, if we take, for example, significant events, they'll want to see your events log. They'll want to see minutes of meeting where it's been discussed. They'll want to see how you're circulating learning points to everyone in the staff. And then they'll want to go and check and get feedback from your staff to make sure that your staff have read those and remembered them. So the focus has sort of shifted now. It's less about looking at your documents and more about checking how things are working, which is difficult, more difficult for us to prove. And we just need to be thinking about that now when we're getting ready for CQC. They also seem to be quite keen at the moment on succession planning. That's part of the well-led quality statement now. And if you don't have a succession plan, you are being marked down in the governance section of well-led. Equally, clinical supervision, which I suppose is a bit of a hot topic anyway at the moment. They are wanting to not just see your clinical supervision policy, but to know how it's working in practice and whether you are doing what you say you are doing, and then whether the people who are being supervised and supervising them feel that that policy is appropriate. So some little heads up for you there. I'm going to hand over to Gary now to start going through the enormous amount of questions that we've had in advance and the ones that we've got in the chat. What I would say, because Rob has gone and not come back, I hope he's
am
okay.
back now.
Oh, you are back. What do you think, Rob? Do you think you can do a quick 10 minutes?
I'll do a very quick one, just very quick, because I think some of it will answer some of the questions that are coming in.
I think hopefully these slides will update quickly. I think that's where you got to.
Yeah, well, it's a good enough place, and then people can ask questions if they need further questions. So apologies, we just lost complete Wi-Fi connection, but it seems to be working now. So how should the PCN company be managed? This is a common question. This ties into the fact that PCNs and incorporation vehicles are separate. They are different. The PCN obligation under the DES is a relationship between all the practices to work together, whereas the company is designed to help you facilitate that and to manage the operations side of it. And the way you manage it really depends on how you want to manage it. You can have it as a arm's length organisation where the PCN board basically commissions the company, and the company could even have different people on the board to run it. Depends on that level of relationship you want between the practices and the company. Or you can have it fully incorporated, in which case you might be sat there, have in one meeting, and the first 15 minutes is PCN, second 15 minutes is PCN company type questions. But it really does depend on how you want to distinguish it. It just comes down to make certain that you understand it and that you've got clear terms of reference with those meetings, so that there isn't any confusion as to what is a PCN decision and what is a PCN company decision. Next slide, please. What type of services should be subcontracted to a PCN? Now, we're going to split them into two categories here of revenue and expenditure, but I've done it as a Venn diagram because there's probably all sorts of initial innovative ideas that could fit in between them. I'm referring to revenue contracts as those that are going to bring money into the company effectively. So that would include those about the relationship between the practices and the company, and effectively the PCN DES, all the DES services. Any contracts, other contracts that you might have with the commissioners, we've got a question about that a bit later on, and any kind of entrepreneurial services you want to provide. So in other words, contracts that you are delivering actively to try and bring money into the business that has a healthcare service element to it, as opposed to expenditure contracts, which is those where you are holding the contract on behalf of your member practices, so that you hold the obligation for it. So contracts with third-party suppliers that might be providing a benefit to all your members, circular arrangements between the practices, centralized staffing type arrangements, for example, and staffing supplier type elements. Now, the tax consequences of all of these and the actual detail of all of these will need to be carefully designed and made certain that the contracts reflect all of that, but we can again expand on that if required further on. How does incorporation impact on the employment status of the workforce? Now, if you've got an existing workforce, which most PCNs will do, in fact all of them will do, who have maybe split obligations between practices, or have a lead practice model in which they are employed by one practice but might work for multiple other practices, then you're in a situation where their employment contract is either with one practice and all the liability goes with that to that one practice, or you have a really mixed bag of partial arrangements, split time arrangements, maybe some sharing arrangements, which may not be as clear cut as you might like, and certainly causes confusion for the staff. It also causes some confusion with regards to potential liabilities and who is responsible should problems arise. If you set up an incorporation, then incorporated vehicle, then you can chupi the staff over into that vehicle, and there is then one employer on behalf of the PCN. And as long as you're set up appropriately, you should have access to pensions. You should have the ability to provide the right indemnities, as Monty has said, to protect your staff and protect the organisation. And you should be in a situation where you can develop its own culture as a PCN, which can reduce some of the issues that we have seen where there is a split position. Next slide, Claire. VAT risks. So what are VAT risks for PCNs? How can incorporation help to manage this? The biggest difficulty with VAT is if the service is, it all basis comes down to what the transactional nature is between the parties and whether or not any exemptions would apply. So the example that we normally go to is a staffing arrangement with the additional roles reimbursement scheme. If you are providing those staff between practices, then there is a chance that that is a VATable service, and effectively you're working as an agency. However, if those staff are providing a medical service as defined by the various orders, then it could be eligible for a VAT exemption. To mix into that, there is a concept of what's called a cost-sharing group, which requires the members of a company to all be exempt from VAT, to be providing and buying services that are within that exemption, and to agree that they're effectively not going to be making profit on that service. So in other words, it's a way of kind of creating a protective bubble around a certain group of services and using that as a way of accessing a valid exemption for VAT. Now, it's an accounting exercise rather than a legal exercise, but it's very important to get it right, because if you do it wrong, then that bubble gets pierced and the VAT man will come knocking. So designing your services and make certain it's clear as to what is and isn't within the exemptions is a very important part of the process. And certainly if you do it right, the incorporation of a provider vehicle has the benefit of largely being VAT exempt, as long as it is providing those health services. Okay, next slide. Does incorporation assist with ICB demands for delivering services at scale? This ties in with a question that came in earlier in the week, the end of last week. in which somebody was saying that they're being pressured by the ICB to try and hold more contracts on behalf of their PCN and other practices. An incorporation allows you to be a contracting vehicle that could hold a contract and then effectively manage it between the member practices. We are seeing that as increasingly the preference of many commissioners. I think they just want to reduce the number of contracts that are being held by individual practices. But some of the other potential benefits would be that you can then provide the services under question and then split the responsibility in the models between your partner members, depending on how you want to utilize it, which ones want to participate, and which resources are to be shared. It does provide a single voice, and it does allow you to isolate the risks associated with those contracts, so that an individual practice doesn't have to take on all the risks associated with potentially providing a large-scale contract across multiple practices. Of course, there are potential downsides of this, of that kind of the cost of doing so. Is you're effectively creating a new management team. You need to make certain that you're willing and able to work collectively at that level of scale. And of course, there's that overarching question of, does that remove and damage the power of individual practices? Those are kind of big ticket questions that need to be asked before you even get to that stage. But from a pure legal perspective, there is certainly a benefit of using an incorporated vehicle to engage with the ICB on a contractual basis. And I'm pleased to say the final slide, so we can get into the discussion, is, does the company need to register as CQC? We have already touched upon, and I don't really need to expand on it much further. I just thought I'd outline what the actual kind of quick test was. Is it a regulated activity? Is the entity actually providing the service, not just holding a contract? Because it only needs to be those providing the services that actually provide it, but it does mean subcontracted PCN companies often do need to. And are there any exemptions that might apply? So physiotherapists, for example, do not need to apply, but clinical physiotherapists providing primary care services likely to be registrable. And then registration required. Now, I've put 24 weeks, but I was being a bit optimistic based on what CQC told me. I have heard it taking, exactly as Claire said, over 8 weeks. I think we saw one a short while ago. It took, 8 months, taking 9 months. So it certainly can take a very long time. And on that whistle-stop tour, again, apologies for the problems. I'll hand over to Gary.
Thanks, Rob. Well, we've had lots and lots of questions, some fantastic questions. We're not going to get through them all, but just to let you know, we'll follow up on email, and you'll have the emails for Monty, Claire and Rob as well. So feel free to reach out to them direct, but we will cover everything on email. So I'm just going to go through the chat, and let's sort of try and cover some of these off in the remaining time. So William Greenwood asks, and I think this is one for you, Rob, what might the impact on already incorporated PCNs in terms of structural and extra cost implications be if they merge with others? And that's thinking particularly around integrated neighbourhood teams and what Fuller and Darcy have said.
Interesting. So we're talking about already incorporated vehicles on behalf of PCN who might want to merge to create one bigger entity.
Yeah, something bigger, thinking of neighbourhood teams.
Yeah, for neighbourhood teams. So it really would depend on how they want to structure it. A couple of things that immediately come out in my mind is it going to completely replace what's being done at the PCN level? If it is, then you would be looking at a merger, in which case you are one practice, one entity would take over another. You would work out whichever one's going to take the lead, much the same as you do with practice mergers, and you would transfer over the assets after negotiating the terms. We have done many of these in relation to federations before, and there are certainly some federations who are doing it with PCNs, so that there is that greater level of scale currently. Wouldn't be able to provide a cost estimate on that at this stage, because it would depend on model. One of the other things I would say, though, is it might be that you end up with ad hoc joint ventures. So you might actually end up setting up another entity owned by multiple PCNs with a specific purpose. So we've in discussions with people who want to set up very specific vehicles to do things such as ophthalmology in the community. And the reason they might do that is they might want to be looking at bringing in, say, some consultants as part of the share ownership potentially for it as extra incentive. So yeah, there's lots to unpick there.
Yep.
And it might be a topic for another time.
Yeah, absolutely. William, I mean, it's a great question, integrated neighbourhood teams. Hopefully that's helped. But if not, reach out to Rob, I would say. But let's stay with William Greenwood's questions and integrated neighbourhood teams for you, Monty. Regarding risks, are there issues to consider going forward if PCNs operate within an INT? If this includes non-PCN organisations who employ staff on shared cared work? And I'm guessing that's the important part, isn't it? The shared cared work.
Yeah, and I think in order to answer that correctly, you probably need to understand the full structure of that actual PCN or company, and what contracts they're doing. But generally, if you're loaning staff from somebody else, will they already have cover? Are they going to take responsibility for those staff when they're out working throughout the network? I.e., will they already have employers and public liability? Or are they expecting you to do it? Who's actually paying the salary of those staff as well? Because ultimately, whoever's payroll they're on, that's who's going to be responsible for them. So yeah, it would be one where we'd probably need to sit down and just understand the makeup of that particular company, just to see where all the risk lies.
Yeah, great. Okay, and Monty, just another one for you again. There's a growing number of practices that are looking at private work. What sort of impact might that have on a PCN policy's costs if you have member practices that are starting to do private work?
It depends how we look at it. If they're a practice who are part of a limited company, and the PCN is actually buying the cover, we would probably look at a policy which could offer professional indemnity, but with that added medical malpractice cover in there. And again, if it is just basic work that they're doing, i.e. in terms of travel vaccines or something like that, it shouldn't be too costly at all. Where we see the difference in terms of costs around medical malpractice when it comes to true private GP clinics or GP consultation, because the way the insurers actually look at it is if you're undertaking a consultation, you could be diagnosing a myriad of risks or offer treatment, all types of different treatment. So the exposure there is a lot larger.
Brilliant. Rob, did you want to add something to that?
I just wanted to add, obviously there is a number of risks associated with doing private services, so make certain before you do any, get advice on it as to what is and isn't permissible. But from specifically in regards to kind of Monty's side and the insurance side, one of the areas to really look at carefully, and from a tax perspective, is aesthetics. So there is a lot of debate as to what is clinically needed, what isn't needed, whether or not it's covered by your insurance, whether it's not covered by your insurance, and whether or not it's vatable or not. Very, very complex area. And I have spoken with PCNs that say, oh, we just want to do a bit of Botox to make a bit of extra money. And it's that just, I say all the time, just is a very dangerous word.
Yeah, no, great. Okay. Rob, we're going to stay with you. This is a question from Kahida Rahman. What if the whole PCN initiative is pulled? What happens to the incorporated PCN?
Okay, so before I address that, I think my view, just for what it's worth, I don't see it going anywhere. It could be rebranded, restructured, but the principle of collaborative working does appear to be supported by the Labour government. And so I suspect that if you take that principle of practices being asked to work together and to continue to provide services together, and think that is going to be a underpinning point, then having a vehicle available that can help you do so in a way that has isolated the risk away from the core GP partnership and the GP liability on that basis would be useful. But let's go to the kind of the scenario in which they say, no, we don't need that anymore. We're going to go fully supporting partnerships moving forward. In that scenario, then you would be looking at a managed closure of the practices. Sorry, of the incorporated, definitely not practices, of the incorporated vehicle. You would have a situation in which you might have redundancies, you'd have to terminate your contracts, and you would have to bring the company to a close. Now, ideally, you should be factoring that into your financial modelling to cover in a risk element to it. But one of the benefits, of course, of being a limited liability is that you have protection if you're unable to meet the bills at the end of it. You do have to be careful if you are a director, because individual director liability in certain circumstances can apply. But as a principle, this model does make it slightly safer than if you were not incorporated and PCNs come to an end, because at the moment lead practices are potentially on the responsible for the redundancy costs for all the ARRS staff that they employ, and they hopefully have good network agreements and possibly cost and liability sharing agreements, but they would be relying on indemnities from the other members of their PCN, and that would include potentially having to take court action against your neighbouring practices in that absolute worst case scenario. But as I say, I caveat it. I personally don't think we'll reach that point, but who knows?
Absolutely, I don't think PCNs are going anywhere. They'll probably evolve. But okay, let's Claire, I've got a question for you. This is, I think this is something we've covered, but it's probably worth clarifying because Chelsea Whiteman and a couple of others have asked about this. And this is, I'm going to read it as Chelsea's written it. You don't need to be CQC registered as a PCN if you are not incorporated. Is that correct? So it's just a clarification about when you do and don't need to be registered with CQC as a PCN.
So I'm flicking back to Rob's helpful sort of flow chart. I wonder actually, sorry to wuss out of this question, but I think Rob might be the better person to answer this.
Happy to do so, not a problem. No, that is correct. Starting point is you're not, which isn't even in the flow chart. But the very, very first bit is whether or not you're a vehicle that needs to, that can be registered as an unincorporated association, which effectively PCNs without a vehicle are. You're not registered. However, you are relying on the registration of your existing members. So if you've got 5 practices as your membership, you will be relying on the the CQC registration of each of them to be able to deliver the services that are being delivered within the practice. And hopefully your CQC registrations will reflect that, particularly if you are a lead practice and you're taking on extra responsibility on behalf of your neighbouring practices. Once you do incorporate, it comes down to those questions of, are you going to be an active provider of regulated activity, or is this a way of just holding the contract and you're still going to be buying the services in from, say, your practices and you're using their regulation? So it's an important distinction. You need to be clear to make certain that you're not accidentally acting in breach of the Health and Social Care Act, as that is, a serious offence.
Yeah, brilliant. Okay, and I think VAT has come up in the chat a couple of times, and I know we've spoken about it, but I think it's worth just clarifying. Does an incorporated entity need to be VAT registered? Rob, probably for you.
I hate these type of questions where the answer is always it depends.
Yeah.
Feel like such a lawyer when I say that, which is useful, I guess. It really does depend on the situation. So you need to look at the transactions that are happening between the PCN vehicle and the practices that effectively you're selling your services to, and you need to think of it as that, as this incorporated vehicle is selling services to the PCN member practices, even if you are as incorporated as you can be and integrated. So in that situation, you need to be looking at, are the services subject to any exemption? And the most relevant exemption is the medical services. which asks what is the primary purpose of that? Is it for the protection, maintenance, or restoration of the health of the person concerned? So if it is, and most of the core, if not all the core DES DES services for primary care networks would fall within that category, it should have an exemption. However, if you're a contract holder and you're looking at just holding the staff, but you're not going to be providing it, being responsible for provision of services, that's still going to rest with the practices. Or if you're looking at doing anything innovative, centralized booking teams, for example, or you want to develop a way of supporting practices from an admin perspective, then there's a risk that they might be subject to VAT because they're not for the purpose of protection, maintenance, or restoration, the health of the person. So in that case, you then look at whether or not you could set up as a cost sharing group, and that has these other rules that are applicable. In all of those scenarios, I would say this, but get legal advice, but also make certain you're discussing this with your accountants, and make certain that your accountants understand the exemptions that are applicable to the medical services. So I always try to point you towards the ASMA practices. And I think I've seen on the chat that Jenna Clark is on there, so I will give her a shout out, as she's always a great person to talk with. But yes, so make certain you do get that advice before you start doing taking too many steps forward, because you do need to understand what it is that you're entering into.
Okay, brilliant. Thanks, Rob. You mentioned Jenna Clark, and she's just asked something in the chat that this might be something you'll know. The previous government confirmed that they'd support PCNs financially if redundancies were needed. Are you aware that this has continued?
Okay,
Is that continued or started?
It's actually a bit of a misconception. So there was a big argument about this when PCNs first came in, as many people might remember. And what they did is they put a compromise that effectively said that the commissioners would be responsible for supporting PCNs in finding alternative roles for the ARRS staff, i.e., the assumption is that they would commission, say, a clinical pharmacist service, or they would commission a clinical physiotherapist service. However, despite what it was often interpreted at, and I actually wrote an article about this at the time, that actually wasn't the same as saying we do indemnify you. It quelled a lot of the concern, but actually it didn't really say anything other than what the statement of law was. And fundamentally, if those staff can't find alternative roles and are entitled to redundancy, there was no commitment that you would get any funding support for that. So there is still that risk there. And I always thought that was a little bit, it was some tricky wording at the time, and we're talking probably late 2019 when that discussion was being had.
Okay, thanks. I think last question, short answers from each of you, and this is one that came into us before. What are your thoughts for any PCN not yet incorporated but thinking seriously about it, particularly in light of Darcy, full of stock take, 10-year plan and everything? Monty, what's your thoughts?
I mean, when we get contacted by PCNs, insurance is probably the last thing on the agenda. So I would say just set aside time just to think about the type of cover that you require. We're very much acting at advisory capacity. We're not there for hard sell, so we'll just tell you the best course of action to take. So just do get in contact, and we're here to help you.
Yeah, Claire.
So I'm going to answer this. Thank you. I'm going to answer this with my mediator hat on, because the other thing I do is I mediate disputes that network practices get into each other when they're in the DES. I think it's important, if you're going to think about incorporating, to be clear about why you're incorporating and whether that why is a shared why amongst each network practice, and whether everybody shares in the kind of the purpose of the PCN, and therefore you're kind of on a shared journey together. If you're not, then that's the kind of scenario where I sometimes get called in a few years down the line to try and unpick it. because people haven't gone in with those intentions to begin with, and conflict has arisen, and it can be a little bit difficult to unpick things. And there's an added complication, I suppose, if you're incorporated. So that would be my sort of one tip. Just be clear about why you're doing it, and make sure that everybody's why is the same. Otherwise, I wouldn't do it.
I'd have said exactly the same as a Federation Director, PCN board member. Do it to unite and move the entity, the organisation forward, because a lot of PCNs struggle with that. Rob, do you want to have the last comment on that as we've hit 2 o'clock?
Yeah, fine. I agree completely. Understand why you're doing it. Make certain you're doing it for the right reason. If you really are taking the view that you need to take control of the INT and to get greater control over your area, as long as you are all working collaboratively and you genuinely have that vision, it's probably the best route to take, because it does give you all the options of being able to hold contracts, negotiate things without having to split it between each of your member practices.
Brilliant. Thanks. Claire, back to you.
Thank you. Well, it's been great to have everybody so engaged in the discussion. I hope it was useful. We are sorry for the slight technical issues. What we will do at the end is we will go through all of the questions that were submitted in advance and the ones that came in through the chat, and make sure we actually answer those people directly by email. And as I said at the beginning, you will all receive in the next few days details of how to access the recording and the slides from this webinar, but also our first one, where we covered some of the more basics about PCN Incorporation. So thanks very much for tuning in, everyone.